Good evening, everyone. I will be presenting a comparison of ultrasound and MRI for disease activity in juvenile dermatomyositis. So this will be a slightly different perspective than the cases that we have seen so far. Juvenile dermatomyositis is a rare autoimmune inflammatory myositis which leads to symmetric proximal muscle weakness and skin involvement. And muscle biopsy and electromyogram are invasive techniques for the diagnosis and disease activity monitoring in JDM. MRI, on the other hand, is a non-invasive technique. However, it is expensive and not widely available. So ultrasound, on the other hand, is a quick, inexpensive, widely available modality, which in experienced hands has the potential to replace MRI for the diagnosis and monitoring of juvenile dermatomyositis. So our aim is to assess the agreement between ultrasound and MRI for diagnosing and evaluating disease activity in JDM. So indicators of disease activity can be clinical and lab parameters such as muscle weakness, skin rash, muscle enzymes, autoantibodies. However, on imaging, we have certain features which can be used to differentiate active and inactive disease. Like T2 hyperintensity in the muscles, subcutaneous and interfacial edema are indicators of active disease, while increased T1 signal, which indicates fatty infiltration, and reduced muscle bulk, which indicates atrophy, are features of inactive disease. On the other hand, increased muscle echogenicity on ultrasound and calcinosis are features which can be seen in both. So ours was a retrospective chart review in which the clinical diagnosis was based on the characteristic skin rash, muscle weakness, along with elevation of muscle enzymes. Ultrasound of the thighs was performed using a high-frequency linear transducer. A non-contrast MRI of the pelvis and thighs was done on a 1.5 Tesla scanner using two sequences, T1 weighted without fat suppression and T2 weighted sequence with fat suppression. The parameters were numerically rated by two independent radiologists, and the radiologist reporting the MRI was blinded to the ultrasound findings. Absolute and percentage agreement was then calculated. These were the imaging parameters that were assessed. So muscle echogenicity on ultrasound and T1 and T2 signal on MRI were either scored as normal, increased, or decreased. Subcutaneous edema and calcinosis was either present or absent, and muscle thickness was either scored as normal or decreased. The overall disease activity was then labeled as active, inactive, or indeterminate. A total of 7 patients were included in our analysis, including 5 girls and 2 boys. The imaging parameters with highest agreement were T2 signal with muscle echogenicity, calcinosis, and muscle atrophy, in which we had an agreement in 6 out of 7 cases. While in subcutaneous edema and T1 signal with muscle echogenicity had a much poorer agreement. However, for overall disease activity, there was agreement between ultrasound and MRI in all 7 cases, with 6 being labeled as active disease and 1 being labeled as indeterminate. So these are representative images from our cases. On this coronal T2 weighted image with fat suppression, we see that there is increased T2 signal, which is bilateral and symmetric, involving the medial compartments of the thighs as well as the posterior compartment muscles. And on the corresponding ultrasound images, we can see that there is increased echogenicity in the muscles. This was active disease. This was another case in which on the axial T2 weighted images, here we can see that there is T2 hyperintensity involving the subcutaneous tissues in the anteromedial aspect of bilateral thighs. And on the corresponding ultrasound image also, we can see that there is increased echogenicity in the subcutaneous tissue. Again, active disease. Calcinosis is a feature which is seen as T2 hypointense foci on MRI. So here we can see that on the anteromedial aspect of the thigh, we can see these areas of calcinosis. On the corresponding ultrasound image, we can see linear areas of hyperechogenicity with posterior acoustic shadowing, which again indicate calcinosis. There were also raised areas of raised muscle echogenicity in the same patient. And on the MRI also, we can see abnormal T2 hyperintensity involving the muscles, subcutaneous tissue. So this was also active disease. This was another case where there is florid calcinosis involving both legs, very well seen on the plain radiograph. And on the corresponding MRI images, there is hyperintensity in the areas of calcinosis. However, the signal in the muscles was normal. Similarly, on the ultrasound image of the same patient, calcinosis was seen very well, but the muscle echogenicity was normal. So this was labeled as indeterminate disease activity. Now, T1 signal and muscle echogenicity are parameters which show poor agreement. And the reason for this is that muscle echogenicity can be raised in edema, which is active disease, and can also be raised when there is fatty infiltration in inactive disease. So in this case, there was raised muscle echogenicity. However, the T1 signal was normal. And this was because there was T2 hyperintensity involving bilateral, symmetrical, medial compartment muscles of the thigh, along with subcutaneous edema in an active disease. Muscle atrophy is also a feature of chronic disease. And in this case, on the ultrasound, there was muscle atrophy. We could see the fascicles and with intermittent raised echogenicity, suggesting fatty infiltration. However, on the MRI, the muscles appeared to be not atrophic. So this was a feature which did not have good agreement. In fact, there was T2 hyperintensity in the muscles as well as the subcutaneous tissue, and this was also labeled as active disease. Even on ultrasound, there was subcutaneous edema. So again, ultrasound was also labeled as active disease. To summarize, ultrasound is a quick and inexpensive modality which does not require sedation, while MRI is costly, time-consuming, and requires the child to be sedated or put under general anesthesia. Both modalities can detect muscle edema. However, it is difficult to differentiate edema from fatty infiltration on ultrasound alone. So how do we overcome this limitation of ultrasound? By using other parameters. So if there is increased muscle echogenicity with reduced muscle bulk, or if the muscle enzymes are not raised, both of these features would indicate that it is an inactive disease. To conclude, imaging markers of active disease are T2 hyperintensity and raised echogenicity, while muscle atrophy and T1 hyperintensity indicate inactive disease. Agreement for T2 signal and calcinosis is high, while for T1 signal it is poor. The limitations of our study were small sample size, relatively subjective criteria, and as we said that ultrasound alone cannot differentiate between muscle edema and fatty infiltration. However, for overall disease activity, there is a high agreement, and ultrasound can be used as an alternate, inexpensive screening modality in children with juvenile dermatomyositis. Thank you.